A 47-year-old African-American male with a history of HIV and an AIDS-defining CD4 count of 50 presented to the hospital with a 3-week history of odynophagia to both liquids and solids. The patient's odynophagia was associated with left-sided chest pain and dysphagia to solids, particularly medications. An EGD was performed to further evaluate these symptoms. Upon entering the distal esophagus, a pseudodiverticulum was noted. There was an active ulcer base seen within the pseudodiverticulum. There were also 2 possible fistulas noted. These findings were located near the GE junction, just proximal to the Z-line. This is a common location where idiopathic HIV ulcers can be found. Biopsies were obtained from the area of active ulceration. Histopathological evaluation revealed hyperplastic squamous mucosa. There was also evidence of acute and chronic inflammation. There was no evidence of viral-associated cytopathological changes. Special PAS stain with digestion was negative for Candidal species. In order to further evaluate the possible fistulous connections, a barium esophagram was performed. The area of ulceration was noted in the distal esophagus. However, there was no evidence of any fistulous connections. This patient had undergone multiple previous endoscopies to evaluate similar complaints. Each endoscopy revealed single or multiple ulcerations in the distal esophagus. Biopsies from these ulcerations consistently were negative for viral cytopathological changes or fungal elements. The end result of these multiple and frequent ulcerations was the development of the pseudodiverticulum noted on his current endoscopy. The differential diagnosis for odynophagia in HIV patients with AIDS include esophageal candidiasis, herpes simplex virus, cytomegalovirus, Mycobacterium tuberculosis, and idiopathic HIV ulcer. The characteristics normally associated with HIV-related esophageal diseases are ulcerations, odynophagia, and dysphagia. Ulceration is a common endoscopic finding in all of the HIV-related esophageal conditions, with the exception of esophageal candidiasis. One potential distinguishing factor between these ulcerative esophageal conditions is the presence of dysphagia. While dysphagia is commonly associated with ulcers of infectious etiology, it is only occasionally associated with idiopathic HIV ulcers. This was not the case in our patient, who presented with both odynophagia and dysphagia. However, in his case, the dysphagia is potentially attributable to his pseudodiverticulum and not the idiopathic HIV ulceration. Idiopathic HIV ulcers are a common cause of odynophagia in HIV patients. They account for approximately 40% of HIV-related esophageal ulcers. The pathogenesis of this condition is unknown. Endoscopically, it usually appears as one or multiple well-circumscribed ulcers of variable depth with normal intervening mucosa. A diffuse superficial esophagitis has not been associated with idiopathic HIV ulcers. Histopathologically, the ulcer tissue resembles that of CMV and HSV, except viral cytopathic effect is absent. HIV ulcers are indistinguishable from CMV esophagitis clinically, radiographically, and endoscopically, and thus multiple biopsies of an ulcer are necessary to exclude infectious etiologies. The mainstay of treatment in this condition consists of systemic steroid therapy, which results in clinical improvement in more than 90% of cases. Because oropharyngeal and/or esophageal candidiasis may be a complication of steroid use, potentially confusing the therapeutic response, short courses of concomitant azole therapy are recommended. One major therapeutic consideration is that steroids may also increase the risk of clinical CMV disease in patients with AIDS. Therefore, before initiation of steroid therapy, a thorough search for treatable infectious etiologies must be undertaken. In the past, direct endoscopic injection of the ulcer base with steroids have been advocated for this condition. However, this is not routinely done at the present time. Another medication which has shown promise for the treatment of idiopathic HIV ulceration is thalidomide. Thalidomide has proven to be effective in healing these ulcerations. The usual dosage of thalidomide is 200 mg by mouth daily for 4 weeks. Although there have been promising clinical results for this application of thalidomide, it has not been clinically approved for this indication. The common side effects associated with thalidomide therapy are somnolence, peripheral neuropathy, and skin rash. Thalidomide is contraindicated in pregnancy because of its well-described association with birth defects. This patient was unable to be treated with steroids secondary to a recent flare of shingles while on IV steroids. Therefore, thalidomide may have been a potential alternative treatment in this case. There are several important points that should be learned from this case presentation. Idiopathic HIV ulceration is a common cause of odynophagia in HIV patients, particularly those with AIDS. The diagnosis of idiopathic HIV ulcer should be suspected when an HIV patient presents with odynophagia in the absence of dysphagia. Endoscopically, idiopathic HIV ulcers present as one or multiple well-circumscribed ulcers with normal intervening mucosa. Multiple biopsies are necessary to exclude infectious etiologies prior to diagnosis of idiopathic HIV ulceration and initiation of steroid therapy. Systemic steroid therapy is the mainstay of treatment in these patients and results in clinical improvement in approximately 90% of cases. And finally, thalidomide is an alternative therapy in patients who fail or have contraindications to steroid therapy.